Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for December 15th, 2022. Today's CME activity code is 487201. This is being recorded and will be uploaded to YouTube by Dr. Baxi shortly after the conference. Please subscribe to our YouTube channel, and that way you can get updates whenever we upload one of our cases. We've got close to 100 on record so far. So we really like people visiting that and join the channel. And if you're not on our emailing list for these conferences, just send us a direct message and we'll put you on. And by all means, always invite any of your colleagues, fellows, trainees, whatever. The more the merrier. We're glad to have everybody. You will be muted except for the faculty. So use the chat box. We'll try to get you to your questions as we can. We have nothing to disclose. And as usual, to ensure patient privacy is preserved, identifying information and or other details have been changed to disguise the identity of the patient and protect the patient's confidentiality. We've got a great case today. There's a lot to learn from this. It's a fun case, and it's Dr. Whittier's case, and I think Bill's going to walk us through the protocol, and then we'll go from there. Thanks, Bill.
Thanks, Roger. Yeah, thanks. Today, we've got a 58-year-old man. He's a Filipino man who has a past medical history of high blood pressure, hyperlipidemia, GERD, and latent TB, who was doing fine until about 3 months ago when he developed a cough and some sinus symptoms, some URI symptoms. He assumed it was COVID. He saw urgent care. They diagnosed him with bronchitis, and they checked him for the viral panel. That was all negative. He was actually given doxycycline by the urgent care for about 10 days. It didn't go away, and he had an upcoming trip to go to the Philippines, and it was still persistently present when he was over there. And so he visited some doctors in the Philippines, and he was given a Z-Pak twice, and as well as an albuterol inhaler. He also had tried some inhaled peppermint, and eventually his respiratory symptoms got better. Another chest x-ray over there was also negative, and he had tested again negative for the viral panels in the Philippines. He denied taking any NSAIDs because he knew that they exacerbate his GERD. And about 3 weeks after he returned to the Philippines, he noted that his urine turned frothy. And 1 week after that, he actually noted that he was getting periorbital edema and bilateral leg swelling, and he gained about 25 pounds. He gained about 7 pounds from his trip, but then he noticed really after the swelling started, he got on the scale and he was up quite a bit. So his past medical history is, as I already said, he had pretty well-controlled hypertension. He had hyperlipidemia, also well-controlled. His latent TB, he's in healthcare, and he was exposed to a patient about 15 years ago, and he took INH and B6 for 9 months. It's supposed to say vitamin B6 there, so that's a typo. No prior sinus issues or frequent sinus infections in the past, and he was up to date on his colonoscopies. Social and family and allergies were really not that significant. His medications, he was on Lipitor and fish oil for his hyperlipidemia. He was on vitamin D for whatever the reason. He's on lisinopril, hydralazine, metoprolol, and chlorthalidone, along with aspirin, Synthroid, and omeprazole. And all those doses were stable. On exam, his blood pressure was a little on the high side at 138/92. He's a relatively fit man and had a BMI that was 22 when his normal weight was 140 pounds, but now his weight had increased to 165 pounds. He was resting comfortably, and really the only thing that was significant on exam was the lower extremity swelling, which was 3+ bilateral edema up to his thighs, and it was symmetric. His labs are here and show that his renal function was normal. His total protein was 5 and albumin was 2. His LFTs were unremarkable. His total cholesterol was almost 500, and his LDL was 192. His triglycerides were 296. His prior panels on his statin were much better than this panel. His CBC was also normal. His platelets were 250, and his serologic workup for nephrotic syndrome was basically negative. He had a double-stranded DNA and ANA that were negative. His complements were normal. His PLA2R was negative, and his serum immunofixation and free light chains were also normal. His rheumatoid factor was normal, as well as his HIV and hepatitis panel. His COVID and viral panel were also negative, And his urinalysis was bland, but it did have 4+ protein, and his urine PC was 11.4 grams per gram with a urine AC of about 60% of that. His ultrasound was also normal with a right kidney of 12 centimeters and a left kidney of 13.6 centimeters without an increase in echogenicity. So he got himself a percutaneous renal biopsy.
Thanks, Bill. Any questions for Bill? All right, that's a first. Let's start with a poll here. Let's see what people think. Anybody that's not a co-host will be able to vote. So what do you think this patient has? Minimal change disease, membranous nephropathy, focal segmental glomerular sclerosis, IgA nephropathy, or amyloid? Maybe we should start saying focal segmental glomerular sclerosis pattern of injury, IgA nephropathy pattern of injury. We don't want to open that can of worms again.
Roger,
Yes, Dick.
I forgot to ask, what does this chest X-ray or CT show?
It was completely normal.
Thanks.
Some good responses so far. Wait a few more seconds here. All right, get those last ones in. All right, I'll end the poll and share the results.
So about half the people think this is minimal change disease. We've got 20% membranous, 16% focal sclerosis, and then 10% each of IgA nephropathy and amyloid. Dr. Gashty, I'd like you to tell me why this is or isn't minimal change disease. What did you vote, and what do you think about each of these diagnoses? Why do you think they're put up there?
I think that there are a lot of features that are consistent with minimal change disease. It seems rather sudden in onset. The albumin is 2, pretty severe degree of proteinuria, so pretty rapid onset nephrotic syndrome. His cholesterol is really high, so that helps make minimal change a little bit higher on my list. Not really sure if there is any connection with his nephrotic syndrome and his upper respiratory infection, whether it was viral. It sounds like it was viral. But I think minimal change looks pretty good. I mean, if I read this in isolation without this prelude of having the upper respiratory infection, I would have I would pick minimal change disease as my number one. Some of the viruses, parvo and HIV and COVID, and some of these other viruses can give you a collapsing FSGS. So I would have actually put probably FSGS if we were to connect the infection to the onset of nephrotic syndrome. I would put probably FSGS as my number 2. Membranous nephropathy, always possible in somebody at his age, but it seems PLA2R is negative, and if it's secondary, it seems like this is pretty rapid onset. So his we've talked about the selective albuminuria and minimal change disease. In this particular case, what is it, 7 out of the 11.4, 7.4 grams of it is, so that's about 65%. So it's not high enough to isolate for, be more pointing towards minimal change. So that's one thing that goes against it. Interestingly, there's really no blood in the urinalysis. This is as pure of a nephrotic syndrome as I've seen. And without any blood, also, I think minimal change disease is probably higher. I think so for high cholesterol, sudden onset, no blood in the urine, all of those things make me think minimal change disease. Other things, IgA nephropathy, obviously this would be the story, except no blood and a lot of protein, and it's very, very rapid onset. So I have a little bit of a hard time calling this IgA nephropathy if there's no hematuria. So I'll just leave it at that. And amyloid, it's always possible that somebody gets sick and this sort of comes out. But it seems like there's, again, amyloid to me doesn't present this, with this kind of an explosive nephrosis. So I think the timeline to me is the deal breaker.
So I think it's interesting, more and more in these conferences, we were talking about the selective proteinuria of minimal change disease, and Dr. Glask's brought it up. And, you know, it wasn't routine that we were able to separate the degree of albuminuria from proteinuria in the past. I know it's done experimentally, but for years we just would check 24-hour urine protein. And now it's so easy to order protein creatinine ratio and albumin creatinine ratio. We're getting a better idea of you know, what patients have, what percent have this or that. What I don't know is, I know that if it's minimal change disease, it often has a very high selective albuminuria. What I don't know is how specific that is. In other words, does the lack of having 90% albuminuria really move you out of the minimal change diagnosis? Dick, can you answer it that way?
Well, it has pretty low sensitivity, but a reasonable specificity. Obviously, the albumin to protein has not been the gold standard for firm selectivity. It's IgG over transferrin, which is seldom done anymore. This probably would lean against a diagnosis of minimal change disease and more favor membranous nephropathy.
I mean, years ago,
I would have expected about 90% albumin if this is pure minimal change, and it's 70%, which is for me quite low.
Steve, you were saying?
no, I was going to say years ago, I think I brought this up before. Giuseppe D'Amico, you know, in Milan, looked at, you know, selectivity in other lesions like membranous and focal sclerosis, and basically showed that the more selective the proteinuria, the more likely those patients would be to respond to therapy with a remission. So, I mean, I don't know that the selectivity is as high as it is in minimal change disease, but you can have, and Dr. Glassick, I'm sure, can speak to this even better than me, but you can have selectivity in other lesions.
Yes.
So Casey, I like your thought about the viral, you know, possible etiology going on as well. I think that's a good point. Giving a collapsing FSGS. I don't know. Again, we start picking away at these things. To have a collapsing FSGS with this much proteinuria and having normal creatinine, I don't know. Steve, can you tell me that if that's unusual or not?
I mean, usually you would expect the creatinine to be a little higher. I mean, it's not 100%, but, you know, more often than not, these patients do have renal insufficiency, and they usually have microscopic hematuria, which, as Casey brought up, this person really doesn't have. So, you know, it's an interesting thought, but I don't know if that's what's going on here. I mean, I was thinking more in terms, and God forbid if I start going down this path, because I'm sure I'm going to get skewered, but you know, the whole issue of an FSGS tip-like lesion, which is more like minimal change disease, would be another thing to consider. But I mean, you know, viral illnesses can trip off these nephrotic syndromes. So I don't know that it has to be parvovirus per se. It could be something else.
Yeah, and Stevie would never skewer you. We have nothing but the ultimate love and respect for you. So,
well, I've barricaded myself in my room here so that
There's a good point brought up in the chat box here that says, with this hypertension on 4 medications, that seems a little unusual for minimal change disease. I think that's a really good point. But yeah, I mean, I think it's difficult. It's difficult to tell. Certainly, the patient has a very high cholesterol. There's a lot of things that point towards the abrupt onset and the cholesterol, the hyperlipidemia, that kind of really want to make you think this is minimal change and maybe an illness beforehand. On the other hand, you know, the non-selective proteinuria, or the non-selective proteinuria, the standard proteinuria and the blood pressure kind of point you towards other things. So it's really, I mean, that's obviously why we do biopsies. Anybody else have any strong thoughts about their diagnosis before?
Yeah, Roger, I just want to point out this patient just returned from Philippines. We don't know this for sure, but there is a possibility of exposure to indigenous herbal remedies or over-the-counter remedies that are contaminated with toxins, including mercury. And the sudden onset of nephrotic syndrome following exposure to mercury can certainly produce membranous nephropathy. And we now know that it's largely an L1 type of membranous. So I would always consider indigenous medicines on the differential diagnosis of a person who has recently returned from a foreign country.
Yeah, that's a really good point. Bill, somebody was, Oded in the chat was, said peppermint nephrosis. I got a kick out of that. But, what about his trip there? Did he take anything?
He's very reliable. He's a healthcare worker. And so he basically told me the only thing that he had besides what he was prescribed was this inhaled peppermint. So I haven't seen peppermint nephrosis yet, but maybe this will be our first case.
You know what? There's always a first for everything.
The only other thing to bring up is this whole issue of amyloid. I don't know if people were basically alluding to AL amyloid, but the guy has a history of TB. Now, assume that his TB is inactive, but people that have TB chronically that's not inactive can get AA amyloid, but I assume that doesn't apply here. His TB, from what Bill was saying, has been adequately treated.
All right. Let's spin the wheel and let's see who's going to read this biopsy here. The wheel up.
Where is the wheel today?
Oh, wait, I might have to read. Hold on, the wheel.
You did it again.
Yeah.
If the wheel disappears, we've got to cancel the conference. That's the shining light of this conference. That and Dr. Corbett. We're always nice to you.
Boy, that hurts, Bill, especially from you.
Sincerity, you think I'm being facetious. It's not true.
The good-natured give and take, right?
Exactly.
Uh-oh. Houston, we have a problem.
It's
coming.
It's coming.
It's coming. See it?
I don't see the video yet, but I see
yeah. Yeah, we're having issues here.
Let's see.
Maybe just bring it in front of your desk.
Oh, there we go. Oh, there.
There we go. Sorry about that. All right.
We wait for the wheel. The wheel waits for no one.
My phone is a problem. Well, Bill can't read his own biopsy, so give it one more spin, and I'll take a fellow. Wild card. I think this is a good case for Melanie.
All right, Mel, give me a second here.
Melanie's our second-year fellow.
All right, I'll give you control here, Mel. I have to make you co-host. So, all right, click on the screen. Yep, you can advance the slides on the right. Yeah, at the bottom. There you go.
Okay, can you hear me now?
Yes.
Okay, I just lost the screen though. Let me see here, go to full screen mode.
Give me a second here. There we go. Then I'll have you click on the screen. Go, yep, you're controlling it. Yep.
Okay, so here we have two cores. Oh, I advanced it. Two cores with the trichrome stain. Doesn't appear to have a lot of fibrosis, which is what we would expect. And it appears to be like a good sample. You can see quite a few glomeruli present. The tubules appear back to back. So I think that if overall, maybe this is like 10 to 15% fibrosis, Dr. Simblick.
Yeah, I agree with you. Yep.
Okay, so again, here we have a medium power view of the two cores again with the trichrome stain. And again, here I'm not appreciating a lot of fibrosis. The tubules are pretty back to back. I don't see a lot of thinning of the tubular epithelium. And then I'll wait until we get to a higher power view to comment on the glomeruli.
Yeah, sounds good. No globally sclerosed in this picture.
Yep, that's true.
Yep.
Okay, so here we have a medium power view of 5 glomeruli. This is the PAS stain. You can see my cursor starting in the upper left-hand side. This glomeruli, glomerulus, the capillary loops are open. There's maybe some mesangial expansion. There's no breaks. The tubules appear back to back. No like the brush border is intact in the tubules. Looking at this glomerulus in the middle, again, this is also, you can see that the capillary loops are open. I don't see any area like stuff like focal sclerosis. I just see like that the mesangium is maybe expanded. Maybe some areas of like hypercellularity here, but nowhere else really. Down here on the bottom right-hand side, maybe these glomeruli are a little bit larger than the others. So a little bit of, I don't know if you would call this like glomerulomegaly. Here you can see the hilum, but again, no areas of like focal sclerosis. They appear quite like normal. I don't know.
Remember, Mel, the glomeruli aren't, they're not all sitting in the same plane. So if you get a cross section, you're going to have some right across the middle and some a little higher up. So I don't know that you can say
Okay.
these are different size.
Okay, that's true.
Yeah, no segmental scars or any type of active lesion. I agree with you.
Okay, so here's a high power view of a glomerulus with the H&E stain. The capillary loops are opened. I don't know. Yeah, they do. I was just gonna say that. I think that they're a little bit thickened.
Yeah, I agree with that.
Mhm.
Focally or kind of throughout the glomerulus.
I think it's throughout.
Yeah.
Even in this one glomerulus in the upper left-hand field, again, the capillary walls look thickened. I don't see any like hypercellularity. The basement, Bowman's capsule is intact. No focal scars.
Yep.
Okay, so here's a high power view of a glomerulus with the silver stain. Looking for spike. Would these over here be like some spikes maybe?
Yes.
And here as well.
Yeah, go over to 9 o'clock. Yeah, there you go.
That's a really nice one right here. Oh, cool.
Yeah. And then holds also on the en face, when we're kind of looking down on top of the capillary wall.
Here?
Yeah, those are still the spikes, but it's just above that, you could start to see some holes.
Yeah, right below the one that you pointed out all the spikes. If you go down below, you'll see an en face cut, and you see all right there.
Oh, okay.
See all the holes?
Yes.
Yeah.
Is that the same thing over here then, or?
Yes.
No?
Yeah.
Okay, got it. Thanks. Okay, so here we have the immunofluorescence for IgG. Sorry, I missed that, Dr. Simblick. No? Okay.
No, I didn't say anything.
Okay, and so if I'm gonna comment on where where it's lighting up, I would say it's in the capillary loops, like the basement. Yeah, in the capillary wall, sorry. There's some staining.
Yeah, kind of, would you say diffuse or more segmental?
Segmental?
Yeah. Yeah, because there's a portion like around 12 o'clock that it doesn't really have any, in there, not a lot of strong staining there.
Mm-hmm. So again, this is another immunofluorescence view for staining for IgG. And again, I guess segmental staining in the capillary walls here and here, maybe some here, but nothing here.
Yeah.
Oh, whoops. Okay, so this is staining for C3. I would say this is like negative. I don't know if this is enough.
Yeah, again, well, a negative would kind of be like a black screen. So again, you kind of have a little more focal than IgG, but this kind of patchy, finely granular capillary wall staining for C3.
Okay.
And then David, IgA, IgM, all those were negative.
Yep, all negative.
C1q, everything negative.
Yeah, no full house.
And kappa lambda, assuming we're also negative.
That's right. They were co-equal.
Co-equal, okay.
And then the PLA2R, is this one more negative, Dr. Simba?
Yeah, that's negative. Yeah.
Okay, so here we have the EM. So here is the capillary lumen. Well, let me just double check here. Is this the capillary lumen here? This is like an endothelial cell.
That looks like a mesangial area.
Okay,
Yeah, there's the lumen.
here. And
Yeah.
then, so this would be the basement membrane, which maybe looks a little bit thick to me. And then if I'm looking for electron dense deposits.
So it looks like there's some spikes where you just were. Yeah.
Yeah.
There's
You'll
probably
see-
some small deposits there. We'd have to see. I can make them out vaguely here. At the higher power, they become more obvious.
They are the higher power, but boy, those are nice spikes that you just pointed out there. Yeah, exactly.
Mm-hmm. Maybe I'll see if there's a higher power view here. Oh, maybe I skipped.
There you go.
There's one.
Okay. So here are the electron dense deposits right here.
Yeah. Which side of the basement membrane?
These would be subepithelial.
Yep. Good.
Epithelial, yeah.
Yeah. You can see the fenestrated endothelium there on the inside. Yep, right there.
Mm-hmm.
And how about the flip processes? How do those look?
They look effaced.
Yeah.
And we don't always get those deposits that electron dense. It's just probably a staining procedure, but they look really nice. That's electron dense. There's no question about that.
Mm-hmm.
Beautiful.
Diagnosis, no.
So what's your diagnosis, Mel?
Membranous nephropathy.
Yeah, and would you want to describe it a little further as far as at least the antibody stain we have?
PLA2R negative.
Yeah, I think that's fair enough. In the chat, there's lots of things thrown out. Dr. Gashty made the point that mercury-induced membranous, at least from the paper he was quoting, is associated with much longer exposure. And if this is an exposure issue, this is a relatively rapid onset. But there's other things. NEL1, somebody said, then the same person, Dr. Punasamy, was saying segmental IgG more keeping with NEL1, and Dr. Reen was asked, did he take lipoic acid? I think Bill said that that he really took was peppermint oil. Bill, were there any other stains?
Well, yeah, I saw him as a second opinion, and this was really all we had at the time. And I asked him those questions, and he really did deny taking anything extra except for those specific things that we put in the protocol.
So with this in mind, with what we have, let's do another poll.
It's interesting, these deposits look, relatively, new, if you will. There's no intramembranous deposits. Kind of goes along with his relatively sudden onset.
Yeah, I think that's a good point. So how would you treat this patient? With a cyclophosphamide-based regimen, a rituximab-based regimen, a CNI-based regimen, or ACE and ARB for 6 months and monitor? It's fun to watch the answers roll in.
Interesting distribution here.
Yeah, it is interesting. Big drum roll for everybody else. but I'm not going to give a spoiler. No spoiler alerts. I'm not going to. We'll get the answer in a second. Everybody vote. Let's see what you think here.
All right. All right, we'll end it there.
Yeah, it's good.
Got the result.
So we've got the highest is by far observing, and then the second is rituximab at 31%. 2/3 say just watch ACE and ARB for 6 months. 31% say rituximab, 3%, and as one of each said, cyclophosphamide or CNI. I'm a little surprised by this distribution. I know the KDIGO guidelines for membranous for the longest time was to just observe and watch, but I'm not so sure with this level of proteinuria that would apply. Dr. Gashti, given what you have so far, how would you treat this patient? Why don't you give us give us the rationale or what pro and con for each of these four options.
And before you answer, I did have some of a workup for malignancy because I think Dr. Corbett asked that in the chat. He had a full body CAT scan of including his head and neck area, chest, abdomen, pelvis. That was normal. His PSA was normal. He'd had a colonoscopy last year that was normal prior to this whole presentation. So he even got antigens like CEA and pancreatic CA19-9, et cetera, and they were all normal.
Yeah, thank you, Steve and Bill. That's important. So Casey, what are your thoughts?
So I think the first question is obviously, do we give this patient immunosuppression beyond, or do we just do ACE and ARB for 6 months? I think, categorizing this as far as, is this low risk or is this severe disease, is this mild disease? This to me looks pretty, albumin of 2 with, 8 grams of proteinuria, it's pretty severe to me. So I don't think I would wait for 6 months with ACEs and ARBs. I would treat, so beyond ACEs and ARB. So that to me, D would be less favorable, although most people, 2/3 of people said D. And then from the other, A, B, and C, Cytoxan versus Rituxan versus cyclosporin, I have pretty much gone to Rituxan for all of these. It's just the ease of use and the low side effect profile, and it's just an easier thing to do, and there's good data to support it. So I would do Rituxan. And I am assuming this is a PLA2R negative primary membranous. So this, obviously with thrombospot and exostosin and NEL1 and all those things haven't been checked. So, but I assume it would be one of those and still would be primary since both biopsy features, meaning not having subendothelial, mesangial deposits, no TRIs, and also the fact that the patient has had at least based on what I'm hearing, a decent primary cancer screening, that this would be a primary membranous. So I'm going to just do Rituxan.
So you mentioned, thrombospondin, et cetera. The list just keeps growing every week. And so I wouldn't expect you to name them all. And who knows when more of those will be more routinely either stained or serologically or both. Some are only available by stain. Some are available by stain and serology, looking for the antibody. But who knows if and when that's going to be available. All we know right now is this is a PLA2R negative. As I look at the data on the response, the remarkable response of rituximab for membranous, even, whether it's PLA2 or not, it's hard kind of not to go to that anymore and to take the ACE or ARB conservative approach. Even if, I mean, I suppose if it was 2 grams and the albumin were normal, it may not be justified. It's just hard not to treat something that's treatable now that we kind of understand it so much better, and our suspicions all along that this was antibody mediated and that we can shut this off. It's hard not to take that approach. I'm a little surprised at the 64%. I would have predicted rituximab for the majority of people, but there's nothing. Cyclophosphamide is getting kind of tossed aside recently, and it's still remains a very good therapy. And I know a number of very respected nephrologists that will go directly to cyclophosphamide simply because it hasn't, quote, failed them, and it may be a faster onset. And then, of course, there's the option of using a combination of rituximab and lower dose cyclophosphamide as a regimen too. So these are all thoughts and possibilities.
And another combination that can be frequently used is rituximab and a CNI together. If you really want to get the proteinuria controlled quickly, the CNI can get it there quicker, and then the Rituxan hopefully could keep it there as you wean the CNI off. So there's a lot of combinations, not just the one that you mentioned there.
Yeah, absolutely. We could, absolutely. That's a very, very popular, very smart, actually. Just use it not immunologically per se, but get the proteinuria down. You take the risk away from the side effects of the nephrotic syndrome, thrombosis, and everything else. And until whatever you attempt to use will kick in, be it cyclophosphamide or rituximab. Yeah, good point, Bill. So, yeah.
The first 2 options here are evidence-based. The second 2 options, the last 2, are not evidence-based. We have very good evidence for efficacy and safety of cyclophosphamide-based regimens, as well as rituximab-based regimens in both PLA2 positive and PLA2 negative patients. The Mentor trial included 25% PLA2 negative, and there was no difference in efficacy. The last 2 have no evidence. There's never been a randomized controlled trial of ACE or ARB and membranous nephropathy, and the observational studies indicate no benefit at all of RAS inhibition unless the proteinuria is consistently above 10 grams a day. So I think if you want to practice evidence-based medicine, the only 2 options that you can pick are number 1 and number 2. And in a patient who had TB, I would certainly prefer rituximab to cyclophosphamide.
Yeah, so that's interesting, Dick, and I'm glad you brought that up because how would you feel, Dick, about, is there a membranous that you would just watch?
What? Membranous what?
That you would just watch, that you would just put on,
non-nephrotic proteinuria and a normal serum albumin I would watch.
Okay.
This patient has severe hypoalbuminemia, and he has proteinuria above 10 grams a day. I would treat him. Now, some might say, well, yeah, but he has a chance of a spontaneous remission, maybe 20%, but that's PLA2 positive membranous. We don't know what the natural history of NEL1 is. And with segmental deposits, PLA2 negative, this is probably 80% probability of an NEL1. And I don't think we should just lay back and not treat it. I would treat it. Probably with rituximab.
So you have at least an 80% chance of being right. We've known that from our experience with you, Dr. Glassick. Bill, you want to tell us?
I would give him better than 80%. Come on.
80%, okay, I know. Bill, you want to tell us?
Yeah, so hopefully everybody can see my slide here. I got the call from the nephrologist, and the patient was still in the hospital, and they told me that this cancer evaluation was normal, and I said, let's go ahead and get him set up to get Rituxan. And we were thinking about giving him a gram before he left the hospital. She repeated the proteinuria without getting the Rituxan on or anything yet, and it had come down to 4 grams. And then within 18 days, without getting anything, it took 18 days. And this patient was extremely reliable because he knew he was tracking his days on the calendar. 18 days later, he had no proteinuria, less than 4 undetectable, completely undetectable proteinuria. So this was the fastest onset membranous I thought I could remember. It was also the fastest resolving membranous. They didn't even change his ACE and ARB. He was on a stable dose of his ARB and they didn't increase it or do anything to it. So he didn't get anything. His cancer evaluation, like I said, was completely normal. But when I met him, we were the story of him going to the Philippines, maybe there was something that he took like lipoic acid or protein or the mercury or something that we talked about. So we sent his slides down to Chris Larson in Arcana, and there we go. And just as Dr. Glassick had predicted from the onset on the history and physical, and then other people started to predict once we saw the pathology, his NEL1 immunohistochemical stain came back as positive. So we now we were assuming that it was going to be that, and we had now a NEL1 case here. So I kind of want to talk about membranous and its many causes. And I want to say that 15 years ago, I gave a talk like this and said, membranous, we don't know the causes. So it's pretty cool to have gone in, since 2009 with PLA2R to then all the other different causes that we've had. I think the science has been really fascinating. I modified this slide from Dr. Canetta from Columbia, which is every single membranous antigen that I could find in the literature to date. Now, this is not supposed to be memorized, but it just shows you that there are more and more coming out all the time. And I put the clinical associations up there that were known. So obviously phospholipase A2 receptor with Beck and Salant in the New England Journal in 2009. And then all these other ones have been described too. Some with lupus, not just exostosine, but TGF beta receptor 3 is also consistent with membranous lupus. And there's some other ones. I think that Dr. Rodby had a case of contactin with a demyelinating polyneuropathy. And so there's all of these that are in there that are coming. And it seems like every time I open up JSON, there's a new one that I have to memorize. And it's quite frustrating because I don't even know what these words mean half the time. And then we get to go in and find out what they mean. So we had NEL1 here, which also was mentioned in the chat as often segmental. So I want to talk about that. Sethi did a recent review that just came out a month ago, and he also talked about the segmental nature, especially when there was a malignancy. But the segmental nature of the NEL1 has been described even in NSAID related and some of the other causes as well. So NEL1 originally came out and there was a 30% malignancy association with it. And so I think people kind of all thought this was the malignancy one, but we're finding out more and more that there are a lot of different causes of NEL1. And I think Sethi was trying to make that point where there's really, he titled the paper, the many faces of NEL1. So there's some that we're just primary, we don't know. There's the indigenous drugs that Dr. Glassick was mentioning, stem cell transplant, infection, sarcoid, and cancer are all different underlying causes. So for this guy, I was really suspicious that there was some drug that he was taking because he had gone to the Philippines and come back with this. And I thought this was one way to get your attention is to have a cute title. And this is a Rodby-esque title of membranous nephropathy from over-the-counter drugs, NEL yes. So I think it's a good way to remember that these drugs can cause membranous. And that makes the most sense to me because it came on so fast and it also went away so fast when he obviously came back and wasn't taking peppermint oil anymore or whatever else might have been in it. And so I just wanted to bring that up with this indigenous medicines. There's this high prevalence of NEL1 nephropathy in the Asian culture. And no one really knows if that's a genetic predominance or if it's that the Asian culture has a lot more indigenous medicines and they are therefore taking these more. And so this study tried to look at that. It was a retrospective study that was recently done, and it was in KI, and they basically took all the membranous patients that had membranous in India in this one study, and they looked at those that had traditional medicine use and found out here that 88% of the membranous patients that had taken a traditional medicine ended up having NEL1. Compared to 9% were PLA2R positive. And if they didn't have an indigenous medicine history, then it was a lot more frequent that it was PLA2R positive. And this slide, I think, says it best. When you look here, you can see the membranous nephropathy on people who were taking native medicines. 58 out of the 66 patients were NEL1 positive compared to without native medicines. only 6, and the predominant were definitely 90 out of the 120 were PLA2R positive membranous, and those are statistically significant. So what are the different indigenous drugs that are associated with it? Well, I don't think we know all of them, but these were the ones that have been mentioned so far. There were 4 cases of lipoic acid. I think that Dr. Reen had mentioned 2 in the chat that had been exposed to lipoic acid, that had stopped the lipoic acid, and the membranous had gone away rapidly without any other immunosuppression. Mercury, as we mentioned, was being associated with it as well. And in this paper, maybe it was a different one. I think that they'd even tested the mercury levels in the serum in some of the patients, and something like 11 out of 25 of them had high mercury levels. So we know that mercury is also associated with it as well. And mercury can be in a lot of different things, not just skin creams or deodorant or the things that we're used to, but there's certain indigenous medicines like these 2 here that contain mercury. And so that could be another possible culprit. And the old classic gold salts, maybe that's really where this is with before we had NEL1 staining, maybe this cationic mechanism of mercury, of gold, are enough to get into the membrane and cause this. And then there's been some with cationic bovine serum albumin as well. So what we actually had here was a spontaneous remission of NEL1 membranous over 18 days. And I think anybody that has NEL1, we obviously do want to think about malignancy, but I think thinking about the exposure to indigenous medicines is important, because if you're able to figure out what that medicine is and you're able to hold it, then you really may be able to avoid Cytoxan or rituximab. And so I kind of think in the future, if I have a NEL1 case, first of all, I may take my time with it, because I'll rule out cancer in the appropriate way, because we know that's a big association. But, not just try to take a really good history, but give it a little bit of time, because if they are off some sort of evil potion that they're taking, this may end up having a spontaneous remission.
Did you find many reports with NSAIDs or NSAID-related compounds?
Yes. In fact, that's what Sethi, I think, had talked about here. There are some NSAID-associated membranous. That's right.
I mean, the original cases, I remember, this was years ago, came out of the Mayo Clinic. And it was always, kind of surprised me, because minimal change is what we usually think of. And occasionally they talked about FSGS, but yeah, it was never quite clear. Do they have any mechanism that they think that NSAIDs, that are associated with NSAID use? Or because you could imagine some of these medicinal things in various countries might have some sort of an NSAID-like compound.
Yeah, absolutely. But no, I don't know what the mechanism is. But you could argue that, maybe all of the ones that were spontaneous remissions were some drug exposure one, and we just didn't know. Maybe all of those over the history of membranous have all been NEL1, or maybe NEL1 has spontaneous remission more than others. I mean, I think there's a lot that we're learning about every day. And, I think this is just, it literally is changing every new month when I pick up Jason.
Yeah, so Bill, that's very interesting. What an interesting case. And I think we all would have treated, and we all would have thought this is the fastest response to rituximab we've ever seen. And not even
pat ourselves
realizing
on the back for how great we are at treating membranous with Rituxan. Yeah, exactly.
Meanwhile, the patient's, just getting the first infusion, and the foot process is already going away. We have a celebrity in the audience. He may not think so, but Dr. Larson from Arcana is here, and thank you for joining us, Chris. Now, if it weren't for Arcana, I don't think we would be half as far as we are with the last 10 years of glomerular pathology and recognizing these things. So thanks for joining us, and thanks for being being part of such an incredible group of pathologists that give amazing pathology, but also write this stuff up. I mean, we as the community as nephrologists are so fortunate to have you and your group there, and you have the foresight to collect these studies and write them up and come up with the title of the year, as far as I'm concerned. So what the NEL? I'm going to start with a question that I just want to open up and some of your experience with this NEL1. How often are you seeing it? When you see segmental, is that pretty much going to point you towards NEL1? Or is this something you're not commonly seeing? I know you guys do hundreds, if not, of biopsies a day. So, Chris, what are your thoughts about all this?
Yeah, it's a great case, really fascinating recovery too. I mean, unbelievable what happened after the biopsy and before the treatment. I was right there on the rituximab vote too, and you know, I was shocked to hear that he recovered so quickly without any treatment. But I guess that's why I'm a pathologist, you know, and not a nephrologist. So, but yeah, so we do see NEL1 quite a bit. I mean, I think in a given year we'll see 100 or so cases of this, and you know, it's probably proportionally increasingly common among membranous cases, because I think PLA2R cases do get biopsied less than they used to. And so, you know, we're probably enriching our membranous cases for NEL1 a little bit more than we did in the past. Yes, segmental, it's not always truly segmental. So when we say segmental, that's kind of like an arbitrary definition where we mean less than 50% of the glomerulus is involved. It's not always truly segmental, but I always describe, which this case was, this was a segmental case. I always say if it's incomplete, the vast majority of these membranous cases, whether that be PLA2R, thrombospondin, almost all of them, it will be 100% of the glomerulus will have positive staining for IgG. So if I can see a few loops where there is no staining, then NEL1 will go straight to the top of the differential just from the histopathologic differential diagnosis. You know, when we, you know, as you mentioned, there are too many of these to stain for all of them. You couldn't possibly stain a biopsy for all of them. And you listed these. I know right now there are papers in press with 7 or 8 more antigens. So to your point, you know, it won't be long before we have 20 or 30 antigens on the list. It's going to be virtually impossible to type them simply with immunohistochemistry. So, but when we do this, when we see a biopsy like this, I almost always stain for PLA2R. Just common things are common. Even though it's segmental, I'll usually just rule that out. But if I see an incomplete IgG pattern, then the first thing I'll do is I'll also stain for NEL1 as well and rule that out. And when you see that, it's not 100%, but more often than not, if there is incomplete staining on the IgG, then the NEL1 will be positive.
Yeah, that's, you know, one thing about membranous is it's, you know, I always say all you need is one glomerulus, and thank God it's segmental and not focal. Otherwise, I wouldn't be able to say that.
Yeah, that's true, for sure.
But we've never seen anything, and you may see 100 a year. This is the first one, and it was your staining that, you know, that bailed it out. But it's really interesting, and the whole concept here that it, I mean, you almost have to think that he got something in the peppermint oil or something else there. It just is too good a story. Dr. Ream had a case that he said. He had a lipoic acid one, and it got better on its own, but it took 6 weeks. But I think we're all learning.
Chris, your standard is the PLA2R negative ones automatically get thrombospondin. Is that the standard, the way that Arcana handles them? Or do you do them all? Do you wait for the PLA2R first and then you go to the other?
Well, in a biopsy like this, I would do that PLA2R and the NEL1 because of what I see on the IgG. If it was a lupus patient, I'd probably just start with exostocin.
Oh, okay.
You know, common things being common and start there. But we don't, I mean, we don't have that whole list of stains validated here even yet. You know, you have to have enough cases to validate an antibody. So until you collect enough cases, you can't even do the validation. So I suspect that we'll move towards more of a, you know, eventually for the rare antigens, more of a mass spec based classification.
Chris, have you seen any kind of evolution in the sense that if you've got an L1, if you catch some of them earlier on, do you see more widespread IgG? And that the fact that it's becoming more focal might be indicative of the fact they're going into remission, if you will, or have you seen any, you know, is there anything that correlates?
Yeah, do you mean, is the segmental indicative of like an evolving, like an early stage? Is that kind of what you're asking?
No, it's more widespread if you were to catch him early on, and now as he's on the you know, at the you know, edge of getting better spontaneously, all of a sudden now the deposits are starting to go away and then you get the segmental nature to it.
Yeah, you know, that's a great question. So for years, until we started uncovering more of these antigens, segmental membranous was a real point of controversy among renal pathologists because there was one camp that said that this is an evolving membranous, either you've caught it early or you've got it late, you know, and there was another camp that said, no, that's not in fact true, because there were case reports and a couple of small case series that showed if you did multiple biopsies on these segmental membranous patients, they would be segmental in the follow-up biopsy as well. And so that is something that is actually it's part of the disease state rather than being an evolution of the membranous. And so now we know that, of course, now we know that these are many different diseases, you know, antibodies directed against different antigens. And so you are seeing different diseases, and that's why some of them have a slightly different appearance. You know, there are other subtleties and other types of membranous as well. It's pretty difficult to tease out all the subtleties on histopathology alone. But yeah, the segmental one is one of the easier ones. You know, when you see that changes the differential.
What's interesting, though, in this case is a great example, and Bill talks about this frequently. He didn't have that many deposits, right?
Mm-hmm. No,
he had
really
diffuse
didn't.
effacement, and he had massive proteinuria. And it's more about the effacement than it is about, you know, it's more about the injury to the podocyte, I guess, per se, than it is about the deposits themselves.
And that's a good point. I thought about the same thing when I was looking at it. This massive proteinuria, it's segmental, and yet it's kind of like focal sclerosis. You know, you see the scar, but it's obviously, which is your point, Steve, it's more of maybe a podocytopathy than just, you know. So I think that's
maybe there's some interaction with the membranous deposits and the podocyte, but clearly it seems that the ones that have more nephrosis have more effusion.
Mm-hmm.
I'll have to go back and reread the famous Polanco Spanish study of spontaneous remission again, because they did identify a few things that were predictive of spontaneous remission in the morphology. But this case is, you know, between a stage 1 and a stage 2 chirg. And my recollection is that beyond stage 2, spontaneous remissions are very uncommon. Whereas with stage 1 and 2, the spontaneous remission rate in primary membranous is about 25%. We don't know what it is in NEL1. I don't know of anybody who's ever done a natural history study of untreated NEL. It might have a higher rate, particularly when it's related to drug exposure. I think Ed Lewis, as a matter of fact, did a study many years ago in repeat biopsies of patients with membranous who had had a remission, and the deposits persisted. I imagine if you biopsied this patient again, which you're not going to do, there would be just as many deposits there now as then. The deposits may be radiolucent rather than electron dense, but the number of deposits probably aren't going to change much in 6 weeks.
I don't know. I really like biopsies, so maybe I should do it.
Well, the renal pathologist always says to biopsy.
Right.
No, that's a great point, Dr. Glassick. I think you're right. I do believe if you biopsied again, you'd still have deposits, which, you know, obviously begs the question, is it a podocytopathy that's actually driving the nephrotic syndrome? Or what is it? You know, the corollary here that comes to mind for me is when we think about amyloidosis. Sometimes you'll see cases of amyloid with very minute amounts of amyloid. I mean, almost, you know, barely visible. And yet they'll be floored nephrotic syndrome. And then you'll have another patient that has amyloidosis, and, you know, they've been treated. They've you know, maybe they've had a stem cell transplant. The amyloid does not go away. So if you rebiopsy the patient, they'll have tremendous amount of amyloid deposited in the glomeruli, but there's no proteinuria, you know? So there's not always a correlation between what you see on the biopsy and the clinical findings. And I've always heard that said, Dr. Fred Silva, when he was here, always said that it's more about the pace of deposition of the amyloid than it is about the amount of amyloid. And it could be perhaps the same in membranous, you know, when something's depositing rapidly and accruing under the subepithelium, maybe you have a higher level of proteinuria, even if there's not as much of the deposit. So
no, I like your, you know, this whole thing with amyloid is another animal in and of itself. And the issue you bring up about the tertiary structure is not necessarily correlating to the severity of the disease. I think that's why the gag mimetics never worked, because, you know, it wasn't about the fibrils. It was probably more about the abnormal protein, whether it be a light chain or transthyretin or something that even if it doesn't form a tertiary structure, it still is a mutated or an abnormally cleaved, if you will, light chain or AA protein. And that in of itself is more, I guess, pathologic than the fibrils themselves.
Mhm.
That's why you have to turn off whatever's being produced. It's not just enough to stop the fibrils from being formed.
Yeah, that's right.
Yeah, and I think, you know, it's still this whole notion of what's going on is interesting because it's something, you know, like Dr. Glassick pointed out, probably the deposits still be there. And, you know, the only thing I can think of that I've seen from a membranous respond this quickly was a patient we had a couple of years back with secondary syphilis and had membranous, got some penicillin, and he was severely nephrotic with nothing. It was not segmental, and there are huge deposits. And within a couple of weeks, his proteinuria started getting better. So I think these are really good examples of exactly what we're talking about. You know, we always look at the deposits and the immunofluorescence and think that's the pathophysiology. And this whole concept of podocytopathy is kind of taking us to a whole nother level.
Yeah.
Any other comments? Well, I got to say, this is a really a learning case for all of us. I don't think it could come at a better time. Thanks, Chris. Your contributions were incredible.
Thanks for the invitation. Yeah, I appreciate
what a treat
it.
to have you, man. That was really, really, really great. I want to end with this great pun. If you saw it in the meeting chat, but the fellow workroom called this a real nail biter. So I think that's very appropriate. Drum roll. What's the case? It was a real nail biter. Anyway, thanks everybody. We will have this up on YouTube for shortly, and keep your email open, and we'll let you know when our next conference is.
Thanks, Roger. Great case.
Thanks,
Thanks, Bill.
Thanks, everybody.